Meningiomas, as the name suggests, are meningeal tumors. They produce neurological syndromes because of compression of the brain and later as a result of brain invasion. They are primarily surgical tumors, and the tumors which produce symptoms are surgically resected. Meningiomas arise from the arachnoid capsules. Etiological factors which have been incriminated include radiation. There is a definite genetic predisposition. Grading of these tumors on the grades of malignancy is from grade 1, grade 2, and grade 3. There are 15 subtypes in all. Grade 1 tumors are curable by surgery alone. Grade 2 is usually surgery followed by radiotherapy, and grade 3 has got a fairly poor prognosis. Surgically, meningiomas are classified depending on their location and depending on their size. We have convexity meningiomas. These convexity meningiomas may be calvariate, that is on the convexity itself, parasagittal, adjacent to the venous sinus, and parafalcine meningiomas, which arise from the falx. Skull-base meningiomas are more difficult to access surgically. There are anterior cranial fossa meningiomas like the olfactory groove meningioma. A little further back, we have tumors of the cellular region which produce symptoms associated with optic nerve involvement and visual loss. Skull-base meningiomas may arise from the sphenoid wing. Again, laterally based sphenoid wing meningiomas are relatively easy to tackle. Mid-third is a little more difficult because vessel encasements may occur, and the inner third or clinoidal meningiomas are associated usually with vessel encasement and are difficult to tackle surgically. Tentorial meningiomas occur either on the superior or the inferior surface of the tent. There are cavernous sinus meningiomas, cerebellopontine angle meningiomas, which sometimes mimic acoustic tumors, and tumors of the petrous apex, which might also involve vessels, making them surgically more difficult to tackle. You also have foramen magnum meningiomas, which can encase the vertebral artery and produce symptoms because of spinal cord compression. Essentially, convexity meningiomas manifest with features of increased intracranial pressure and with brain shifts. They can present with seizures, especially when brain invasion occurs or by pressure alone. Focal deficits may present depending upon the location of the tumor. These deficits might be motor, may affect speech, or in the case of certain occipital meningiomas, may affect vision. Skull-base meningiomas produce some classical clinical syndromes. Olfactory groove meningiomas, with the pressure on the frontal lobe, can produce personality change. They can also produce anosmia, seizures, and sometimes a Foster-Kennedy syndrome with ipsilateral optic atrophy, contralateral papilledema. Tuberculum cellae meningiomas generally manifest early when the tumors are small because optic nerve involvement and visual loss occur early. CP angle meningiomas produce what is called the CP angle syndrome, but hearing loss is not an early or classic feature. Foramen magnum meningiomas may produce hemiparesis or even a brown sick water syndrome. On imaging, meningiomas are seen as extra-axial tumors. The only possible difference is in the rare intraventricular meningioma which arises from the choroid plexus. So in a classical meningioma, there is a CSF cleft adjacent to the tumor. There is a dural tail which shows the degree of dural involvement. These tumors enhance uniformly. Meningiomas may be associated with brain edema. This occurs especially when there is brain invasion. Shifts occur. Herniations can occur because of the mass effect. Meningiomas may produce bony involvement. This is, of course, applicable to skull-based meningiomas, and this has got therapeutic implications. For example, in a sphenoid wing meningioma, an orbitozygomatic approach has to be done with care because the involved skull base may fracture during craniotomy, which might result in damage to the optic nerve or the internal carotid artery. MRI provides optimal information regarding a meningioma. A T1 weighted image with contrast delineates the tumor well. T2 weighted images are useful because T2 shows the vessels very well, and the relationship of the tumor to vessels can be clearly seen. FLAIR images show the degree of brain edema, which indicates the possible potential brain invasion. MRA and MRB are important to diagnose vessel encasement. This is very important in anterior cranial fossa meningiomas and in parasagittal meningiomas to see if the sinus is involved or occluded. This is important for surgical planning. This brings us to the topic of embolization. Embolization is useful because it decreases the vascularity of a meningioma and can make surgical resection easier. However, embolization should be done with care. For example, in an olfactory groove meningioma, supply will be forthcoming from the branches of the ophthalmic artery. So, attempting to embolize this tumor may result in occlusion of the ophthalmic artery and visual loss. In the basic principles of meningioma surgery, we have 4 Ds, which were described by Al-Mafli. These are de-dress the tumor, that is, define the tumor and separate it from the surrounding brain. Devascularize the tumor. This is achieved by coagulation and cutting of the base. Decompress the tumor, that is, decrease the volume of the tumor by intratumoral decompression. And then finally, the last step is dissect the tumor, remove it. In convexity meningiomas, surgery is relatively easy. The craniotomy is tailored depending upon the tumor location. Once the dura is seen, the dura from which the tumor arises is coagulated, and then the dura is cut around the tumor. Dissection should be done with care as the tumor is separated from the brain to coagulate all the vessels which might be communicating to the brain matter. If this is not done meticulously, postoperative hematomas can result. Parapulsine and skull-base meningiomas are more difficult. Skull-base meningiomas, especially CP angle meningiomas, olfactory groove meningiomas, and sphenoid wing meningiomas, especially middle third and medial, are best done after placement of a lumbar drain. There is a potential danger that a lumbar drain might result in a herniation syndrome. So usually a lumbar drain is placed preoperatively and kept closed. The lumbar drain is opened after the dura is opened. Devascularization of the tumor involves coagulation and cutting of the attachment of the tumor to the fox or to the skull base. This is usually done in tandem with intratumoral decompression. Intratumoral decompression of the tumor facilitates the rolling of the tumor away from vessels and nerves. A grade 1 Simpson resection involves a total excision of the tumor with the overlying dura and involved bone. Grade 2 is total tumor excision with coagulation of the dural attachment. Grade 3, there is a tumor remnant. And grade 4 is a partial removal. Management of meningiomas is primarily surgical. These patients merit anti-seizure medication, especially if they are undergoing a surgical procedure. If the person has never had a seizure, about 3 weeks of anti-epileptics can be done, after which the medicines can be stopped. If the patient has a seizure, anti-epileptics are usually continued for about a year, after which a reassessment can be done. What is the role of radiotherapy? Radiotherapy is given in grade 3 tumors, in grade 2 tumors after resection if there is a residual, in grade 1 tumors if there is a Simpson grade 1 or even grade 2 resection. Usually radiotherapy is not even considered. Simpson grade 3 might merit radiation. Many meningiomas are managed without surgery. They are just observed. This depends on the size of the tumor. Small tumors, which are asymptomatic. Location of the tumor. A deep-seated tumor in a patient where symptoms are minimal. Age of the patient is also a factor. Older people with small tumors do not require surgery. Meningiomas arise from the arachnoid cap cells. These are extraaxial tumors, except for intraventricular meningiomas, which may arise from the choroid plexus. 85% of meningiomas are benign and slow-growing. Multiple meningiomas may occur in neurofibromatosis too. The modality of treatment in a meningioma is primarily surgery. However, observation is a possible option in incidentally detected tumors, especially in older people. Surgical difficulty in meningioma treatment depends primarily on the location. There are vessels or nerves which can be compromised. Medial sphenoid wing meningiomas may encase the ICA. Falcotentorial meningiomas may be related to the great veins. Tuberculum cellae meningiomas involve the optic foramen and compromise the optic nerve early. Endonasal endoscopic approaches can be used for tumor removal in midline small tumors of the anterior cranial fossa.